Thank you very much to the organisers for inviting me today. I think before I start, I just have to show you this slide to indicate that my hospital benefits from income from carrying out a number of drug trials related to the topic of today's meeting. Just to give an outline, my intention was to talk about a number of things. First of all, and the most important bit as far as I'm concerned, symptomatic treatment for people with Huntington's disease, and particularly symptomatic treatment for the behavioural or psychiatric symptoms, which is the area that I'm most interested in. I was initially planning to talk a bit about the some of the exciting new treatments that appear to be coming along and are currently at the clinical trial stage. But then I realised that Lauren, who's one of the speakers this afternoon, is going to be talking on specifically that topic. So I'm going to leave that subject area for Lauren to cover this afternoon. But I do want to then come back at the end and just have a few remarks about what I think the implications of some of these new potential treatments for Huntington's might be for the way that services are delivered and organised for people affected with Huntington's and for families, genetic counselling services and so on. Okay, so I always like to start with this slide, which is the person, George Huntington, an American doctor who gave his name to the condition we're talking about today. So he came from a line of GPs. Some people think there's a gene for being a doctor, and indeed his father and grandfather were both doctors before him. And he published his article on Korea just a year after he graduated from the medical school in Columbia University in New York. So I slightly suspect that he'd been working on it as some kind of dissertation or student project related to his degree. But in his paper, he very nicely, he talked about other causes of chorea, the involuntary movements that people with Huntington's disease get, but he talked also about what he called the hereditary chorea, and he described this condition which is characterized not only by motor symptoms such as involuntary movements, but also cognitive difficulties and also behavioural or psychiatric symptoms. And this, in one quote from his paper, he talked about how the nervous temperament greatly predominates, and he talked about the tendency to that form of insanity which leads to suicide. So I think it's absolutely clear that George Huntington recognized that this was not only a neurological disorder, but it was also a psychiatric disorder, and much of what I want to say in my talk is relevant to that. This is a picture of Prestwich Hospital in Manchester, one of the two county asylums for the Greater Manchester area. And I'm old enough that when I was a junior doctor training in psychiatry, I did some of my training at Prestwich Hospital. And when I talk to the older members of the Huntington families who come to my clinic, many of them still have memories of relatives being taken away to hospitals like Prestwich, and there they remained for the rest of their lives. And so it was at that stage taken for granted that psychiatrists were the professionals who looked after people with Huntington's. Now, mercifully, the old asylums have all closed down, and the treatment is now community-based treatment. And actually, when it comes to community treatment for Huntington's, most people assume that it's the neurology clinic that's where patients will be looked after. But I have been arguing for a lot of years that, that actually it's the behavioural symptoms rather than the motor and the cognitive symptoms which cause the most distress and have the biggest impact on quality of life, but both for the individuals who are suffering from the condition and also for the rest of the family around them. And we actually showed in a major study a few years ago called the TRACK-HD study, we showed that there was actually a stronger relationship between loss of what we call functional capacity. Functional capacity is the opposite of disability, if you like. The relationship between functional capacity and the behavioural symptoms was stronger than it was with the motor symptoms. So I think there's a third point that I would like to make about the psychiatric symptoms, which is that actually we have a whole range of treatments that are already on the market and in regular use today. I'm talking mainly about pharmacological treatments here, a whole range of treatments which work for the behavioural symptoms of Huntington's. So everyone says, well, we haven't yet got a cure for Huntington's, but if you think back to 25 or 30 years ago and to what happened to people going into the back wards of places like Prestwich Hospital, they were looked after, but they weren't receiving any kind of treatment at all. And I think in the past 25 years, one great advance which has happened for families affected by Huntington's that nobody seems to quite notice is that we've got very much better at symptomatic treatment. And the outlook for someone being diagnosed today with Huntington's, even without taking into account the future possibilities that Lauren's going to talk about this afternoon, the outlook is already much, much better than it was for somebody 25 years ago being diagnosed. So what I'd like to do is sort of run briefly through what I call the behavioural phenotype of Huntington's, the major psychiatric symptoms that people get and how we can deal with them. So the first thing is clearly that people with Huntington's experience a mood disorder. So part of that is low mood, sadness, depression, call it what you will. And unquestionably, a number of studies over the years have shown that there's an increased risk of suicide for people with Huntington's compared with the rest of the general population, and that is probably at least partly related to the mood disorder, the low mood. I should say anxiety often accompanies sadness in depression, and it does in Huntington's as well. So there was an excellent study done as long ago as the 1980s by Susan Falstein, who is a very well-known American psychiatrist, and she did a study in 1980 to determine the prevalence of Huntington's in the state of Maryland. She worked in Baltimore. As well as trying to ascertain all the people who had a diagnosis of Huntington's, she applied a psychiatric interview, a standard research psychiatric interview called the Diagnostic Interview Schedule, which was the kind of state-of-the-art research tool at the time, and applied the criteria, the so-called DSM-3 diagnostic criteria of the American Psychiatric Association, to figure out on a lifetime basis how many people had suffered from depression, schizophrenia, etc. And she found that 33% of her sample had met the criteria for major affective disorder, that's serious depression, at some point in their lifetime. And another 5% had met the criteria for a less severe kind of depressive disorder called dysthymic disorder. And she compared that with a study that had been done in Baltimore a couple of years earlier using exactly the same methodology, which had basically interviewed people picked from the telephone directory, and had found that the lifetime prevalence in that study of major depression was 4.3%. So you might look at this and say, well, it sounds like depression is 8 times more common in people with Huntington's than it is in the rest of the population. Now, actually, this kind of approach to psychiatric epidemiology is a little bit flawed when you apply it to a condition like Huntington's. So I'm just showing you here, this rather complicated slide shows you that in order to get a diagnosis of major affective disorder, you have to have had 5 or more of this list of symptoms at roughly the same time. And some of them are obvious things like low mood and so on. But I've coloured some of these symptoms in yellow because I wanted to highlight the fact that some of these things are things that you might well have if you've got Huntington's, whether you've got depression or not. I mean, it's pretty obvious that sleep disorders, slowing of thinking, cognitive difficulties and so on are potentially attributable to the Huntington's itself and not to a mood disorder. So I think Susan, when she did this study, overestimated the frequency of proper depressive illness in the Huntington's population. But that's not to say that we don't see in a very high percentage of the people who come to the Huntington's Management Clinic, we're talking to them about low mood and anxiety, and these are a significant part of the clinical picture that they're reporting to us, and they cause significant distress. Susan, in her studies, also did a little sort of side study where she looked at the families of people who had Huntington's and had depression, and compared them with the families of people who had Huntington's but had never had depression, and she came to the conclusion that depression with Huntington's runs in families, and that there are families where everybody gets depressed when they get Huntington's and families where that doesn't happen. Now, and at the time she said maybe there's 2 different genes. Well, we know that's not true now. We know there's only one cause for the Huntington's in everybody. But we also have learned over the intervening time since 1980 that actually genes play a part in predisposition to depressive symptoms in the entire population. It's not that there's a depression gene. There are lots and lots of genes which collectively make some people more vulnerable to get depression and anxiety than other people are. And so I think that's probably the reason that Susan found this tendency for depression to run in certain Huntington's families. They were just families who also happened to be a bit above the average in terms of genetic predisposition to depression. And there's interesting work going on now within the Huntington's network and in the behavioural working group of the EHDN. We've been collaborating with the people who do the clever genetic studies, so-called genome-wide association studies and so on, and we're looking into this relationship between psychiatric symptoms in Huntington's and the genetic background, quite apart from HD. And I'm not going to release any of that information now, but it is quite interesting and it will be coming out soon. Okay, so how do we treat depression? Well, the bottom line is that depression in people with Huntington's responds just as well to, if not better, to antidepressant treatments than depression does in the general population. But there are a few differences. The similarity is that actually the modern antidepressants, so-called selective serotonin reuptake inhibitors, these are the common ones that people are prescribed for depression nowadays, are very much the medical treatment of choice for depression and anxiety in people with HD. So these SSRIs, as they're called, are drugs like Prozac, proper name fluoxetine, citalopram, sertraline. Many, probably quite a few people in this room will have taken those drugs, and if you go to your doctor with depression as a general member of the public, then you probably will be prescribed one of these. Generally speaking, if you take a drug like citalopram or fluoxetine, the sort of standard dose is 20 milligrams a day, and that usually works for depression. People with anxiety states usually need to be treated with higher doses, typically 40 milligrams a day. And when you look at people with Huntington's who've got significant depressive symptoms, they often don't respond to the standard antidepressant dose. They generally need the anti-anxiety doses to make a difference, which might be telling us that the depressive symptoms in Huntington's are a bit different from garden variety depression. The other difference, which I think is quite important, is that if I went to my doctor and said I'm depressed, they'd give me citalopram, say, and after a few weeks you're feeling better, and then they'd say, okay, take it for another 6 months and then you can stop. If you take it for 6 months after you get better, the research suggests there's a low risk of relapsing. It's my experience, and I've been doing a Huntington's clinic since 1992, so that's quite a lot of experience, that when you stop the antidepressant 6 months later, it's about 3 weeks after that they're on the phone to you saying, I'm back at square one, you're going to have to put me back on the tablets. It seems to relapse as soon as you stop the antidepressant. So nowadays, I don't bother to try to take them off the antidepressant until later in the illness when the whole situation's changed and it's clearly no longer necessary. So that's two important differences, I think, between garden variety depression and depression in Huntington. Okay, now other antidepressants work as well as the SSRIs, so the two main other groups are so-called monoamine oxidase inhibitors, which are a bit old-fashioned now, and tricyclic antidepressants. I try to avoid tricyclic antidepressants because on theoretical grounds they might make the cognitive problems of Huntington's a bit worse. So my preference is very much for the serotonergic type of antidepressants. And then the other thing to say is, what about psychological treatments? If you look at the research on depression in the general population, there's clear evidence that psychological therapies like cognitive behaviour therapy are just as effective as antidepressants, and actually that cognitive behaviour therapy and antidepressants is more effective than either of them on their own. They probably work on the problem from different angles, but you know, both help to interrupt a vicious circle at two different points. There hasn't been much research into psychological therapies for symptoms of Huntington's. In fact, it's absolutely in its infancy, but there is now a working group in the EHDN focusing on psychological therapies, and we have recently finished a pilot study which I was involved with, but led by colleagues at the University of Lancaster who were using mindfulness-based cognitive therapy for these symptoms in people with HD. And it was only a pilot study, not big enough to draw conclusions about whether it worked, but we certainly, as the doctor who was referring people into the study, I was hearing a lot of very favourable comment from the people who we referred. So I hope there's going to be follow-on research on this, and I think that this this may have a lot of potential. Okay, now the second big symptom I want to talk about is irritability, which means developing short fuse, finding that you get annoyed over things that you would have taken in your stride previously. And that goes along with difficulty keeping your temper once you are irritated, or difficulty, I can feel really irritable at work sometimes, but I wouldn't let colleagues or patients see that that's how I felt. But people with Huntington's not only are more irritable, but they have more difficulty hiding it, and they tend to have angry outbursts, and then they always feel, well, they always report feeling absolutely terrible afterwards that they behaved like that, but it often collapses as quickly as it flares up. But it can be a huge problem, and it can be a huge problem for the people who are living with HD sufferers, and I would say it's the number one issue we deal with, the practical issue that we deal with in the HD clinics. And there's lots of psychological reasons why a person with Huntington's might feel irritable. You know, life is a bit frustrating if you've got Huntington's. Sometimes you're too clumsy to do things. Sometimes people can't understand what you're saying to them. There's lots of cognitive overload. When I get irritable at work, it's usually because of cognitive overload. I'm trying to do 2 or 3 things at once, and then people come along and knock on the door and say, can you just look at this? Or, and there's just that eventually makes you feel very cross. People with Huntington's, one of the cognitive changes that happens early is they have great difficulty with multitasking, and so cognitive overload is a way of life for somebody who's got Huntington's and some degree of cognitive disability as a result. And you can equally see that when it comes to actually displaying anger, there are psychological aspects here. So people with Huntington's develop a little bit of what's sometimes called emotional blunting, difficulty being able to read other people's emotions, and that makes it quite hard to figure out what people's intentions are, and difficulty looking forward and foreseeing the consequences of an action. So, you know, if I punch this person on the nose, what's going to happen? Well, we'd normally hold back from doing something extreme like that because it would have consequences. But when forward planning's affected, that plays a role, I think. But I personally think also that there's a straightforward neurobiological reason for this. I think that, I know that we know from studies like Track HD that there's clear evidence of degenerative changes in a number of different major pathways in the brain many years before people develop overt symptoms. And some of those pathways are ones that are sort of inhibitory pathways from the parts of the frontal lobe that sort of act as the calming down center, if you like, in these sorts of situations. So I think it's a biological problem, and it's such a universal problem. It's not just certain personalities who get this. So what can we do about it? Well, psychological treatments for like anger management classes and that kind of thing don't really seem to work, and I think that's because of what I was saying about the causes of it. But it does help a lot to work with families and caregivers and make people understand the right techniques for dealing with it. It's no good if somebody's getting cross with Huntington's, it's no good saying just you behave yourself. That is going to push their buttons and make them a lot more cross. So you have to use distraction techniques and things like that. And that sort of training is vital. But then it's also possible, I think, to use medication, and those selective serotonin uptake inhibitors are again the thing. So high doses of SSRIs in my experience, make a huge difference to the irritability from Huntington's. Now, there are other drugs that you can use as well. So there are the mood stabilizing anti-epileptic drugs. There's a range of those that's sometimes used. And the so-called major tranquilizers, drugs like olanzapine and sulpiride and so on, which definitely have a calming effect on people who are irritable and get angry. But the problem with the neuroleptic drugs, the major tranquilizers, is that they worsen some of the other symptoms of Huntington's. They worsen the apathy, they slow the thinking, they, they're helpful for suppressing involuntary movements, but they worsen the slowing of movement, which is the bigger problem for physically for someone with Huntington's. You don't fall over because you've got involuntary movements, you fall over because when you get off balance you can't move quickly enough to get back under your centre of gravity and recover your balance, so you fall over. And neuroleptics make those things worse. So I try to use them as the last resort treatment when the other things aren't working, and I find that the SSRIs will often manage the situation for several years before you need to move on to stronger medication. However, I do find that you always need to use the top doses of the antidepressants to get an effect, and then when that stops working, I resort to what colleagues sometimes disparagingly call the California cocktail, but I mix an SSRI in the morning with another serotonergic antidepressant called mental block, mirtazapine at bedtime, and using that combination seems to be very helpful. So the other really big two other big behavioural problems, so-called apathy. Apathy sounds a pejorative term, doesn't it? But loss of drive and spontaneity and sort of motivation is universal in people with Huntington's. It comes a bit later, but it comes to everybody. We did a study some years ago, a lot of years ago, where we started developing the questionnaire that's now used to look into the behavioural symptoms of Huntington's, and we did what's called a factor analysis, and here you can see the apathy type symptoms plotted against duration of illness, and you can see they all just get worse as the condition goes by, whereas the irritability and anger tend to sort of worsen in the middle stages and then fade away, and the depression and anxiety type symptoms tend to be equally frequent throughout the course of the illness. But this perhaps shows you, so here you can see, I hope, that that the apathy symptoms are mainly in people who are diagnosed or at least in the prodromal stages, and they tend to be worse in people in the later stages than they are in the early stages of the disease. So very much something that tracks the progression of the disease. And how do we treat apathy? Well, it's one of the most difficult things to treat. So educating family and carers is again really important. In the UK nowadays, it seems to me that professional carers are taught that they shouldn't suggest to the people they look after, let's go and do such and such a thing, because that's imposing their ideas on the patient, and that encouraging patient autonomy means you should wait for them to say what they want to do. But if they've got Huntington's and they've got apathy due to Huntington's, you'll wait forever for them to come up with a suggestion. So I argue that it's essential that there's a structure and a program of activities, and that the carers are proposing activities which the person they're looking after can then enjoy. So structured environment is a very important thing. Now, there are no established treatments of drug treatments for for apathy in Huntington's, although I do have to admit nobody's done a trial of amphetamines or anything drastic like that, but a clinical trial recently looking at bupropion, which is a drug which on theoretical grounds might have made a difference, didn't make any difference at all. So I think the key lesson as far as drug treatment and apathy is concerned is that there are drugs like the neuroleptic drugs which worsen, they reduce drive, they worsen apathy in people with Huntington's, and so trying to avoid those drugs, neuroleptics, tetrabenazine, etc., is really important if you can manage to avoid them. Okay, now a couple of remarks about what we call perseveration. People often talk about obsessive symptoms in Huntington's, but it's not strictly that. So perseveration is very common in the middle and late stages of HD, and my definition of it is that it's the repetition of a thought or a behaviour or even an emotion which has persisted and carried on well beyond the original psychological context in which the thought or behaviour arose. So just to sort of explain what I mean by that, sometimes people will, an affected person will go on asking the same question over and over and over again, and no matter how many times you answer it, they still ask you the same question. Or they may get obsessed in inverted commas with a particular theme. I had a patient who got absolutely obsessed with the idea that her husband should buy 4 horses for the 2 of them and their children, even though they lived in a small house in the middle of Preston with a tiny garden and nowhere to keep horses, and they never had. But he said she mentioned them at least once an hour, and there was no subject of conversation that couldn't be subverted round to talking about horses. And he used to send me little notes before she came into the clinic saying, whatever you do, don't mention horses. But it can be a behaviour too. So you see patients who just keep doing the same thing over again. I have a patient in a nursing home who he gets a cigarette out, lights it, 1 puff, stubs it out, immediately gets another one out, lights it, 1 puff, stubs it out, and if someone doesn't take them away, he'll go through the whole packet doing that. But it can be emotions as well. So years ago, someone asked me, why do people with Huntington's sometimes take an irrational dislike to somebody in the family? And I hadn't a clue at the time. I now realise what happens. Got a lady with Huntington's, she has a row with her daughter, say, and the daughter flounces off, and the next day the daughter comes back as usual to visit, and you'd expect by the next day it would all be forgotten and over and done with. But the very sight of the daughter brings all that anger instantly flooding back, and it's just like where they left off the quarrel. And that can go on not just for days or weeks, but that can go on for years. This is different from an obsession in that people with obsessions recognise that the obsessional idea is wrong in some way, and they try to resist compulsions to do things arising from the obsession. And people with perseveration don't do any of that. They often have no insight at all into it. It's therefore really difficult to come up with psychological treatments because people don't have that awareness of what they're doing. But again, the high-dose SSRIs sometimes make a difference. And we did a study a few years ago looking at what Huntington's experts use to treat these things, and you'll see that the first choice drug was overwhelmingly an SSRI, and the first alternative choice was overwhelmingly clomipramine, which is another serotonin boosting antidepressant. So I think that rather validates it. My last behavioural symptom was insomnia or difficulty sleeping, and I think most people with Huntington's get problems with sleep. In many cases, it's not so much insomnia, but it's rather sleeping at the wrong time, a kind of day-night reversal. And that can be very difficult to treat. Giving sleeping tablets at bedtime just makes them sleep more during the day instead, and it doesn't seem to matter what time of day you give these sleeping tablets, it makes the problem worse. I find that sometimes melatonin can be helpful. We may hear more about that this afternoon, possibly. But maybe about 50% of people get some improvement in the day-night reversal with the melatonin. Otherwise, rather than sleeping tablets, I tend to use sleep-inducing antidepressants like mirtazapine, which seem to be more successful. Okay, I was going to talk a little bit about the organisation of treatment, but I think I've run out of time, so I'll stop there, but I'll be around at lunchtime if people want to ask questions about any of this.